Noon. This is the Kidney Cancer Journal Roundtable, Cancer Clinical Trials Post-COVID-19 Pandemic, Challenges and Opportunities. I'm Bob Figlin, the Kidney Cancer Journal editor and the Spielberg Family Chair at Cedars-Sinai Cancer in Los Angeles. And I'm really very happy to be joined by three distinguished kidney cancer and GU investigators from across the country. And my colleagues and friends, Bob Motzer, who's the Jack and Dorothy Byrne Chair in Clinical Oncology at MSK, Professor of Medicine at Weill Cornell Medical College, and Head of the Genitourinary Oncology Service. Eric Jonash, a Professor in the Department of Genitourinary Medical Oncology and the Division of Cancer Medicine at MD Anderson Cancer Center, the Director of the VHL Cancer Center at Anderson, and Co-Chair of the Renal Cancer Program at Anderson. And lastly, Bradley McGregor, Clinical Director for the Lank Center for Genitourinary Oncology at Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. Gentlemen, thank you for taking the time out of your busy schedules to join us today. So really, the purpose of today is to gain your insights into how we're all thinking about delivering GU cancer care during the post-pandemic world. So Bob, let me start out with you and really focus on your view of the role of delivering immunotherapy to COVID-19 patients and whether you modify, alter, think about, screen. How do you think about that process when you're delivering immunotherapy to our kidney cancer patient population?
Well, the COVID-19 pandemic really impacted in a dramatic way on our practice in many different ways. For one, it made it difficult for patients to access our care at our cancer center in Manhattan, it also made it difficult to deliver cancer care to our patients, our RCC patients in Manhattan. In terms of access to care, patients were screened in terms of coming into our clinic. They were also concerned about coming into Manhattan with the COVID-19. And so, in many times, standard patients would postpone standard follow-up tests and put that on hold. It also made it difficult to evaluate patients on treatment. So, I mean, in return for that, we really boosted our our remote medical care with we're using videos and so forth, and that has been an extreme challenge, because it's really new to us. For the most part, we've all been practicing hands-on in-person visits. So it really forced us to become, from a tech standpoint, familiar with these forms and be able to use that. So that has been a real challenge. It's also been a challenge in terms of managing people with metastatic kidney cancer who are on therapies. Because for the most part, in the past, you gained so much from seeing somebody in clinic and talking to them and getting their blood work done, and rather than to speaking them to a distance and not having the comfort level of actually seeing them in person. So it became difficult from that standpoint. It also influenced the doctor-patient relationship, which is very important for medical oncologists, having a very close relationship, and so there was basically a barrier put on that. It also made it difficult for clinical trials. And so I think that the number of patients going on clinical trials decreased during the pandemic. Patients did not want to come into centers to get on clinical trials. They were more concerned, and there was more of a concern about experimental medicines and their side effects and the impact on that on COVID infection. And it also made it much more difficult to assess patients from a safety standpoint, because a lot of our safety assessments were compromised by the lack of ability for patients to come in and get evaluated. I think it also impacted on our treatment to a certain extent. For many patients, there's an opportunity to start therapy, or there's an option to delay it. And so I think that with the uncertainty around the pandemic and the uncertainty around, say, immunosuppression with the use of steroids, that influenced our decision in terms of when to start patients on systemic therapy and delay it. So it really it was really an extreme challenge to manage, our population of patients with metastatic kidney cancer during the active period of the pandemic.
So that's a great summary. So Eric, in Houston and Anderson, I mean, some of the patients that I've seen over the last several months that have now been getting vaccine, we're also starting to see some of the lymphadenopathy associated with the vaccination, and you're having to interpret, is that lymphadenopathy related to the cancer or related to the vaccine? It's dramatic changes for us. So how have you been able to manage that in Houston? And the bigger question is do we as organizations, should we be establishing some more coherent guidelines about how to think about our post-pandemic kidney cancer treatments? What are your thoughts about that, Eric?
Yeah, so a couple of things here, Bob. I mean, the first of all is the guidelines that exist that have been developed by ASCO and ESMO with regards to general administration of immunotherapies, management of immunotherapies are excellent. And I think, we can certainly use as good guideposts on how to treat people with immunotherapy, how to manage immunotherapy-related side effects. Layering in then the specter of COVID, number one, what happens to an individual who's on immunotherapy who then gets COVID? How does that affect how we treat that individual? Unfortunately, a number of my patients have been infected with COVID while they've been on active checkpoint antibody therapy. And it's difficult to say on an individual or on an anecdotal level whether or not they have suffered more than an individual who wouldn't have been on. There are some data suggesting that outcomes in cancer patients are worse than people who are without cancer with COVID. So I think that it's probably impacted them to some degree. I think that the last question, or the next question really is as we then assess these individuals from a response perspective, would the intercurrent development of COVID or the vaccination, which also induces lymphadenopathy, create complications? And the answer there is yes. There's no question that when you're then looking at an individual who's had COVID, who has pulmonary metastases, who has inflammatory changes, which are hopefully improving, to be able to then do a RECIST assessment on that person if they're on a clinical trial is a challenge. So it certainly created challenges, but not insurmountable ones. And I think the last question really is, and with the vaccines that are coming out, should we now not vaccinate individuals because of potential risk? And the data have been a little mixed, but there has been a recent paper that came out just in the Lancet Oncology from Weissengren et al., an Israeli group, suggesting that the toxicities associated with IO therapy as a function of treatment after vaccination are not dramatically different. And so when my patients asked me, should they get vaccinated, I said, from a toxicity perspective, I think that it's probably better to have a COVID vaccine than to get COVID. From an efficacy perspective, I think it's still an unanswered question. If you get a COVID vaccination, will this worsen outcome from IO therapy? There we still do not have answers.
Yeah, that's a brilliant summary. So Brad, in Boston, let's just turn our attention to designing clinical trials. I mean, I think, we all do international trials with blinded independent radiologic review. If you put a patient on a trial with kidney cancer where the kidney cancer is spread to certain areas and they've been recently vaccinated, how does one actually accomplish, measurements? So how do we need to be thinking about clinical trial design and placing people on trial kind of post this pandemic when we want to ask and answer the important kidney cancer questions, but we don't want to have that complicated by things that are unrelated to the things that we're doing therapeutically?
No, absolutely. I think that's a great question. I mean, I get my radiology reports for patients who are on our trials, and they're like, oh, there's an increase in lymphadenopathy in the left axilla, correlate with likely recent COVID vaccine, right? So our radiologists are already putting this in the reports on a on a routine basis. And so they're doing that, but how do we take that and put that into, like you said, that blinded independent review? And I think it's something that's really, it's a difficult question to answer at this point in time. I think it's something we're gonna have to certainly think about. Do we have these different caveats in there? Like, do we say, oh, they had a recent COVID vaccine, and do we interpret that? We start looking at criteria and ignore certain lymphadenopathy that may be related to that vaccine. Because from a clinical standpoint, our radiologists are doing that off trial all the time. And so how do we incorporate that into trials?
Yeah, but just to push you a little bit, Brad, no, I agree with that completely, and maybe Bob can weigh in as well. I mean, most of the trials that Bob has reported, that Eric's reported, and you've reported, are international trials. And it means that they're not all patients that are being entered in Boston, New York, and Houston. And obviously the rest of the world is not exactly in the same place that the United States is. They may not have the same imaging evaluation as the Farber has. How are we going to do these pivotal international trials post-COVID-19 when a substantial part of the population of patients entered on that trial may be entered ex-US in places that have not had the vaccine or getting the vaccine later? Any thoughts about that, Brad?
Yeah, I mean, I think overall it is challenging, but if you look at, like, from what I've seen from like the COVID vaccine lymphadenopathy, I mean, often those lymphadenopathy may be some lymphadenopathy, but it's often not large enough that you meet RECIST criteria for a new node. So if you're like strictly going by RECIST criteria, you may not actually, you may have some enlargement nodes, but by RECIST criteria, you may not meet that. So I think that's the fortunate thing. I mean, often not getting like 3 or 4 centimeter nodes from a COVID vaccination.
So I want to stay on this topic just for a little bit, Bob. I mean, you've led some of the major international trials in kidney cancer. Thoughts about how the data sets will evolve over the next, let's say, 6 to 24 months, and how we're going to be interpreting that data and how to navigate that? Any thoughts about that?
Yeah, I mean, so we don't really know what the impact of the pandemic will be on the clinical trial data. I think that has been somewhat industry sponsor specific. The various sponsors have had their own plan in place to monitor follow up and safety during the COVID-19. So, in terms of the studies that I'm involved in, I'm not aware that there has been a dramatic impact on safety for these trials. There was one study that I was involved with where there was an issue in terms of getting imaging follow-up on patients because of COVID. So that was observed in one trial, and I think that is going to be that's going to be something we're going to have to deal with. But in point of fact, we really haven't, for the big phase 3 trials, we really haven't seen the data come back yet, so that we can really kind of adequately address the situation, be aware of the impact that you're speaking of. And I've been also impressed by the adenopathy that's associated with vaccination. I mean, I've never seen any other scenario where somebody has a vaccination and I see it occur on scans after the vaccine. And in point of fact, the first few people that I managed that happened in, that they were called progression on the scan. The radiologist said this is progression, exactly. And one radiologist said, well, this is not progression. This looks like something we've been seeing. And so, I mean, it really has been quite impressive. And so for what we've been doing is we've been timing the scans around the vaccine, because I don't think it's a good idea for somebody to have a scan on a study 2 days after they have a vaccine. That's the phenomenon. But if you do it 2 days before, it'll be less of an issue. And we have noticed that the adenopathy is really quick to resolve. So I don't think it'll be a problem with repeated scans, but it is an issue. And I think that it would certainly affect straightforward RECIST. Certainly, blinded review, core imaging review, where people would not know whether there was a vaccine that was responsible for that. So I think it's a difficult situation to resolve.
No, but I think this is it's a wonderful conversation, because I think just from the 4 of us, it may be that the timing of our imaging in relationship to vaccination should become part of what we're thinking about in the data sets, so that we're at least removing the variables that we can remove from our evaluation of anti-cancer therapy. So Eric, let me turn to you and ask a question about just therapies. I mean, we've had patients on antibody, we've had patients with obviously with that need steroids and anti-IL-6 antibodies when they're getting immunotherapy. So how are you navigating through the conversation with your fellows and your patients about the appropriate role for, the managing the side effect profile, especially for the immune-related adverse events associated with immunotherapy?
Yeah, so I guess the big question is, are we changing how we're doing this for individuals in the COVID era? And the answer is no. We are clearly using immunomodulatory agents like steroids, like IL-6 antibodies, TNF antibodies, which can have an impact on immunosuppression. But I think it becomes a competing risk argument. Which is more important, managing the side effects that the patients are having, the severe side effects from the immunotherapy, or dealing with the potential increased risk of infectivity while they're on those treatments? I think one of them you have to manage. You have to manage the toxicities. You can also manage risk to exposure by making sure that individuals have safe practices. We know now that the CDC has said you don't need to, if you're vaccinated, you don't need to wear a mask anymore, and there are relaxations of guidelines at a national level. But I think that for our patients, especially our vulnerable patients, we should probably continue to urge caution and a conservative approach to the risk of exposure, which can then mitigate that second factor.
So I want to turn, Brad, to you, and I want to change the conversation a little bit for all of us to talk about the impact of telemedicine. And I think Bob made an absolutely critical point. I mean, the relationship between the medical oncologist and their patient inside that patient care room it's a very intimate setting, and we share, life important information that is not exactly captured by something over Zoom as we're doing today. So two questions. One is, how have you incorporated telemedicine? And the second for you, Brad, is do you think that there will be increased telemedicine going forward as the pandemic winds down, or is that just going to dissipate? Brad, you're on mute, I think.
Sorry. That's a great question. I think telemedicine is here to stay. I mean, I think there's certain aspects of it that patients just really enjoy. And I think, we've been able to function with telemedicine to an extent. And I think telemedicine will likely be incorporated into medicine going forward. I think it's important to realize that telemedicine is a nice adjunct to in-person care, but I don't think it's a replacement for in-person care. So I think, telemedicine has its role if you intersperse that between in-person visits. But I had one patient who was just scared of coming to the clinic on a VEGF TKI, and she didn't want to come in for 4 or 5 months. And I was like, I really want to see you in person. I need to see, like, how are you actually doing? What do your hands look like? And get a better sense. And so I think it comes that fine line where we need to use telemedicine in conjunction with in-person visits. And I think that goes the same for clinical trials as well. I think as we look at the future clinical trial designs, I think we can look to incorporate telemedicine as an adjunct and sort of look to where can we replace an in-person visit and with something over the phone and labs remotely, but not to completely get rid of that in-person care. Because
so what would be your recommendation to our colleagues in the community where, it's hard for us to deliver, 3 to 5 months worth of VEGF receptor TKI therapy without ever seeing the patient? Mm-hmm. I mean, when do we finally say to the patient, I need to look at you, I need to put my hands on you, and in order for it to be safe, I need to have that doctor-patient interaction? What are your recommendations for our community doctors that are increasingly, from what I hearing, well, I'm afraid to come in, just let's do it through Zoom?
Yeah, I mean, from my standpoint, I think obviously I see it up front. I think when I started VEGF TKI, I'm checking labs probably every couple of weeks for the first month or so. And so I feel comfortable doing maybe a telemedicine visit at 2 weeks, but in a month I'll be like, hey, I really want to see you in person to assess, bring a blood pressure log. And it doesn't put more onus on the patient, because now, some of that data collection that we would do in clinic comes from them. And so I discussed, hey, this is going to be really important. I'm happy to see you virtually in 2 weeks. You have to get the labs. I want you to do a blood pressure log. I want to have more of a sense on actually what's going on here. And it really comes down to individual discussion with that patient. Some patients after those discussions say, hey, listen, you know what? I realize there's actually a benefit to come in, and I will come in 2 weeks to see you. But I think it just comes down to each discussion with the patient.
And Bob, what's been your experience in Manhattan with your large patient population?
So, I mean, I think that video medicine is a really great tool that we need to incorporate into the care of our patients. So what I found is particularly useful for our patients who are getting, say, routine follow-up with scans and blood work, and maybe are cancer-free or don't require systemic therapy. And so for them, doing a scan and talking on Zoom is, it seems reasonable. But really, in terms of people who have significant severe medical problems or who are on systemic therapy, I mean, you really need to be seeing those patients. I mean, I think the other aspect of this is that in addition to just providing medications, I mean, we provide a tremendous amount of emotional support for patients, right? And so I found that it's much more effective to provide that emotional support and contact in person than it is either on the telephone or on a video screen. And so I think that that's another component that really requires seeing the patients. But in terms of the timing, I think it's an individual. It's an individual in terms of the physician preference. It's an individual dependent on the needs of the patient. Certainly some, say, safety visits for people who are on chronic TKIs could be done by Zoom. On the other hand, people are having symptoms or pain or are having very difficult time with regard to family situations. I mean, those patients need to, they're better off seen in person.
Yeah. And Eric, I mean, I also, many of our patients that come to see us see other healthcare providers. They see our social workers, they see our dietitians, they see our supportive care medicine. What's been your experience with the telemedicine experience in Houston?
Yeah, it's clear that there are some advantages and disadvantages to telemedicine that Bob and Brad have outlined here. The access to other specialties in a timely manner, I think, is a deficiency. Access to labs, let's say the labs are done locally, and being able to have them in hand when you're speaking with the patient. Access to imaging. So these types of things, I think, are downsides, and the comprehensive care, I think, to some degree gets diminished. However, I would actually venture to say that from a social context perspective, because patients still cannot bring loved ones into their hospital with them, being able to have a conversation with the patient, with their spouse, with their children on Zoom, where we're not wearing masks and we're having this conversation, I find in some ways, because they're in their home environment, because we have that half-hour period instead of more of a 15-minute period where we can actually chat, I find that there are some advantages from a standpoint. Patients find that it's more of a conversation with a friend on Zoom than it is a conversation with a doctor. So I think there's some aspects to it that are very good. It needs to be improved. What could we do? We could, for example, incorporate wearables where if we want to have vitals on the patient, their Apple Watch 4.0 will be able to provide that information to us prior to us actually seeing the patient or while we're seeing the patient. There are, I think, advantages and disadvantages. Clinical trials, which we're going to be talking about in a minute, efficiencies of being able to actually have these visits that we want, intercalating them with in-person visits, I think, is the future. And I sincerely hope that medical authorities around the country will see that as being an advantage.
So Brad, we're all GU doctors. I mean, this is obviously kidney cancer centric, but I'd just like to get a sense from the three of you of whether you've seen patients presenting with a bit more advanced disease because of maybe not seeing the physician early enough. And we all get many of our referrals from our surgical colleagues, our urologists. What are your thoughts about that? I mean, we don't necessarily need to speak about prostate cancer where that's happening as well, or bladder cancer, but is there a clinical substantive delay in care that we're starting to experience and worry about in the kinds of patients that you're seeing?
Yeah, I mean, I think that's a great question. I think from a GU standpoint, it's more challenging because if you look at something like kidney cancer or bladder cancer, there's no screening that's in place. So, patients often present with symptoms of disease, or we find the kidney cancer because they have appendicitis and we find an incidental renal mass. So I think it's unclear to me how that's going to play out. I haven't seen patients in my clinic who've had hematuria that they've ignored for 3 months because of the pandemic. Generally, they say they still see the primary care doctor. They give them a call on the phone and they say, okay, you really do need to see a urologist, and they sort of proceed with that workup. So within GU, I haven't seen it yet, but I think time will tell as we sort of move forward. How does this change with prostate cancer? Are people getting less PSA screenings, less follow-up for that? And so I think we'll have to see.
And Bob, I know at Cedars during the height of the pandemic, where we were having hundreds and hundreds of patients in the hospital with COVID, there was really a postponement of surgeries. And that postponement of surgeries was for all types of surgeries, elective and non-elective. And yes, cancer patients still came in, but often the surgeries were postponed a bit. What's been the experience at MSK?
Yeah, and that's exactly the same situation we had at Memorial, where during the worst part of the pandemic, a lot of the operating rooms were actually turned into ICU rooms with respirators for COVID patients, and a lot of the surgeries that were considered non-emergent were not undertaken, were postponed, and so that was it was a very difficult situation for, say, patients who had a kidney tumor waiting for their nephrectomy. I think that's another aspect in terms of the way the pandemic has affected us. Now, I have to agree with Brad's point. Now, I haven't actually noticed in person that there's people presenting to me with delayed diagnosis because of the COVID with kidney cancer. I mean, I can't say that I've noticed that personally. I mean, it certainly seems like a reasonable trend, but I mean, I haven't observed that with people with our disease.
So Eric, let's turn our attention to kind of the world of clinical trials in kidney cancer. I mean, pretty clearly, over the last 15 years, the advancements that we've made in kidney cancer have been a direct result of aggressively placing patients on trials, asking important pivotal questions, and moving drugs and therapeutics through the system in a way that's unprecedented in our disease that we all manage. How do you think we need to start to frame, the clinical trial portfolio, whether it's IITs or industry-sponsored research or novel therapeutics that might have the impact on your immune system? What are your thoughts about that as a leader in this area?
We need to clearly improve. We need to take the lessons from the COVID pandemic in terms of how we can make clinical trials more efficient into how we design our next generation of clinical trials. And Bob, as you know, I'm the head of the Kidney Cancer Research Consortium, a DoD grant-funded mechanism that allows us to try to use informatics solutions to create efficiencies in clinical trial design and execution. I think broadly speaking, as a field, we need to embrace that. It is challenging for patients to undergo treatment on a clinical trial. There are logistical differences. It is more challenging for them. It's a sacrifice that patients are making on behalf of others that are going to have kidney cancer in the future. And we have to make that sacrifice as minimal as possible. And the other thing that will happen if we do actually apply things like, for example, virtual visits, some type of remote monitoring type strategies, and that we're going to make clinical trials less expensive, safer, quicker, more efficient. So I think it's a win-win situation, and we really have to think about this.
So Brad, let me ask you, I mean, should we be, for example, if you were designing a clinical trial tomorrow in kidney cancer and it was a 1,000-patient trial, international, should we be stratifying for whether the patients had COVID or didn't have COVID to make sure that the arms are balanced? Should we start to think about integrating some of these questions into our designs to make sure that we're really evaluating for the effects of the treatment and not the comorbidities that the patients are undergoing? What are your thoughts about that?
Yeah, I mean, I think it's challenging. That's a great question. But then the question is, how do you find if someone had COVID or not in a certain area? And like, do you check antibody levels? Is this from the vaccine? Is this not from the vaccine? So I think these are great questions. I think it would be very challenging to realistically do that going forward. I think some of this data we need to look at is to see what are the effects of COVID just in patients with cancer. And so there's a lot of registries trying to look at that. We have studies trying to look at the effects of vaccine efficacy in patients on systemic therapy for cancer, be it immunotherapy or chemotherapy, and looking to try to see what are the antibody titers, how do the vaccines affect these patients overall, like the side effect profile and titers. So I think until we really know how this affects and how can we assess COVID, I think it becomes very difficult to design a trial stratifying by that, because how do you, in a country where how do you know if someone actually had COVID or not? Do you base on antibodies, or it just becomes very challenging.
So in our last few minutes, you guys have just been spectacular, but in our last few minutes, I just want to kind of go around the horn and start with you, Bob. You know, as we think about kidney cancer and all of our accomplishments, I think we all do not want to see the COVID epidemic postpone or delay further success. And how are you thinking about that when you're meeting with either your junior investigators, your faculty that are under your guidance, or industry that's so important in our plans? How would you want us to be thinking about that going forward?
Well, I mean, I think from one point, it's important to do what we can to minimize the effects of COVID, right, and the impact of COVID. So I think that encouraging vaccination is very important for patients not only in the U.S. but outside the United States. And I have that conversation with all my patients. I recommend that they get the vaccination. And so I think that, and I think the other is a point that Eric raised, and that is also use an adequate protection. So I think for patients who are treated on the clinical trials, to make sure that we are enforcing the need to wear a mask or to use protection to protect ourselves as best as possible. We certainly don't want to see the COVID pandemic truncate our progress in kidney cancer. And so I think along those lines that I think it's important to have conferences like this where we discuss the impact of COVID. We make people aware of COVID and its potential impact on clinical trials and how we can best, kind of ameliorate that or conduct clinical trials in the setting of the pandemic. And so, one of those has been, telemedicine in terms of doing safety evaluations with telemedicine. That minimizes patients coming into centers and getting exposed. And I think that's been very effective in the United States. It would be a wonderful thing if it could be implemented outside the United States. The vaccination, and also, just really education to patients and physicians that we really haven't seen a detrimental effect of either the vaccination or of the potential for COVID on the effect of our immunotherapy or the adverse event profile. So I don't think it's a reason to stop clinical trials. It certainly has been a distraction, but I think, efforts like this should help us focus on continue our efforts in clinical trials in RCC.
Thanks, Bob. And Eric, in your role in the Department of Defense and the funding of clinical trials, I mean, it's so important to have leadership like yours across the country. Are there special questions that we should be asking in the context of the post-pandemic world in kidney cancer that will influence questions that we want to ask and answer and how we approach patients?
Bob, I think the two key questions we want to answer first are, does treatment with immunotherapy worsen side effects from immunotherapy? The second question is, does having COVID or a vaccination alter the ability to respond to treatment? This is, I think, we have an opportunity probably with some of the trials that were winding down as the pandemic occurred to do some retrospective analyses to be able to see whether or not we can tease some of these important questions out. I think moving forward, it's going to really be a question of what is going to be the issue with COVID moving forward. Are we actually going to have this controlled at a national level? Will we have it controlled at an international level? And then I think the important questions there are going to be, you know, efficacy of immunotherapy as a function of vaccination.
And Brad, lastly for you, you're the clinical director of the Lank Center, a very important center nationally for our GU studies at the Farber. I mean, how are you taking kind of the macro view as an institution to contributing to this effort?
Yeah, I mean, I think when COVID first happened, everything came to a screeching halt for like about a month. Like in March of 2020, it was like nothing happened. We were stopping collecting samples. But then, you know, we quickly sort of started coming back, and we started taking samples in, and we started adapting to the system and trying to incorporate those things. And overall, I would say like our clinical operations from a trial standpoint, clinical operations now are very close to where they were pre-COVID, just using telemedicine as an adjunct. And I think even throughout the pandemic, I think we've seen clinical trials have been successful. Cosmic 313 like accrued rapidly despite COVID. Prosper, you know, is just completely accrual. So I think, you know, well-designed, smart trials, you know, can continue to thrive in this setting. They just have to be engaged with the patient institution to make sure that everyone's thinking about how to incorporate this going forward.
Well, that's great. Well, gentlemen, it's been a pleasure hearing your thoughts. It's always nice to see friends and colleagues. I wish you and your family safety. And I think our community will welcome, as Bob mentioned, welcome conversations like this that can start to inform both how we think about it as well as how we should think about it going forward, especially in the context of not losing the momentum to address this difficult disease because of COVID, and still wanting to accomplish all the things that we can still accomplish in this setting. So thank you all for your time, and be safe.
Thank you.
Yep, thank you.
Thank you.
Well done, men.
Beautifully moderated as always, Bob. Thank you.
Thank you.
All right.